Precision capsulotomy centration, 180i study. Why is centration of the capsulotomy important? I think we all realize that a nice robust capsulotomy can be a great foundation for surgery, but also for the IOL as postoperatively. We know that if it's decentered and there is incomplete coverage, this can lead to early onset PCO and even asymmetric fibrosis, which can lead to IOL decentration and tilt. This is important for all IOLs and patients, but optically, multifocal IOLs and torics are obviously going to be more sensitive to decentration and tilt. The goal for capsulotomy is quite simply to be centered on the IOL, and hopefully this yields a nice symmetric 360-degree coverage, and that's what we'd like to achieve. But it's kind of a chicken and an egg scenario. Where will the IOL be located in the eye? And then what is our target? Because obviously we're creating the capsulotomy first, but we want to center it on the IOL. So the only real way to address this is with a little bit of intelligent thought, looking at all the options and conducting a clinical study to see what plays out. So this is a 180i prospective case series. We have 3 arms: pupil centration, Trypan capsular landmark centration, which Pavel talked about earlier, and the coaxial Purkinje image as our centration landmark. There are 3 groups: pupil centration, centered on the dilated pupil; Trypan capsular landmark centration, centered on the dark, intense capsular stain; and 3 being the coaxial Purkinje image centration group. We basically see wonderful correlation between the Purkinje images and the Trypan landmark. Well, now in the statistics, and for an anatomical system, this is a very significant correlation. What we'd like to see, of course, is a nice capsulotomy centered on your Purkinje image or your Trypan landmark or on the pupil, and all yielding a nice IOL centered on the capsulotomy. In the study, we had a small number, about 5% of eyes, that actually achieved all 3 criteria. Interesting. So that, there's obviously some very symmetric eyes out there, but it's not every eye. And I think we need to look at beyond the 5%, the 95%. So now if we use the group 1, that we have asymmetric IOL coverage. We have IOL coverage in all situations, but we actually see the decentration, and we can see it's actually somewhat random. It's not predominantly nasal, superior, it's kind of all over the place, and this may well be due to the fact that the pupil dilates asymmetrically and there isn't a strong anatomical preference. As we'd expect, we can see the decentration of the pupil center relative to the IOL. These types of capsulotomies, there is a high degree of decentration between the IOL and the capsulotomy. The average is 0.3, but there is a range. And as we kind of go towards the edges here, 0.5, we're obviously at the edge of the range. And this might be more of the example of this IOL here, where we basically have a 5mm capsulotomy, 1mm one side and virtually nothing on the other side. And of course, this may have some tilt and instability long term. We look at the second group, the Trypan capsular landmark centration. This yields excellent symmetry for the IOLs and capsulotomies. We can see here the Purkinje images in the patient with the IOL in the central region of the multifocal lens. Very high correlation as you expect, half as much decentration as you would see with pupil centration, a much tighter distribution and the maximum displacement being 0.3. We move on to the coaxial Purkinje centration group. We see, again, very similar symmetric IOL coverage, and the statistics are very similar to those reported previously. And just looking at the decentration of capsulotomies relative to the IOLs, we can see here the range on the left-hand side being favorable and then becoming more decentered to the right. And using group 1 as the control group, we can see that both the coaxial Purkinje image is superior to pupil centration, and the Trypan landmark indeed is also superior. And these two are equivalent. So some nice statistics here with a p-value of less than 0.05. To verify the results, we used Callisto Eye, but reference matched the IOL master data. So here is shown the visual axis as measured by the IOL master, and then we have superimposed on here a diameter of 5 millimeters and then 6 millimeters. A way of thinking about these two sizes is that the 6 millimeter represents the optics body and the 5 millimeter represents where ideally the capsulotomy would be located. And we can see for the pupil-centered group, we do achieve some nice centration, absolutely, in some eyes. But in the majority of eyes, we see decentration, and actually quite major decentration here. This is what we were seeing in the other images, that when the IOL is there, 6 millimeter optic body, the capsulotomy can be very close to the edge. Now, looking at the Trypan capsular landmark group, we see excellent consistency with the capsulotomy actually being centered on the visual axis and 5 millimeters being achieved. And this is what we're seeing with the IOL body too. It's nicely spaced around here, allowing for some deviation. Indeed, here we have slight deviation, very minor. I think we'd all be happy if we had that as well. The coaxial Purkinje image group, again, same story as for the Trypan group. Excellent correlation with the capsulotomy being centered on the visual axis. This is not what we intended, but this is what the data shows us. So it's showing us that the IOL is actually quite predictive to be on the visual axis, and intuitively we know this because multifocals and torics would not work that well if that did not occur. Just have a look at some capsulotomies here. We'll actually look at a full case in a moment, but the capsulotomy is in 1/3 of a second, centered on the Trypan landmark. If we look across a varied range of cataract patients, we can see we can still get excellent centration, independent of whether they be premium lens patients all the way through to nice white cataracts or pseudo exfoliation patients, small pupil, weak zonules. This is actually a multifocal toric planned and used, and great visual outcomes at the end. Kind of an incredible thought process to be going from premium precision in this type of patient. This is enabled by using true centration, i.e. Purkinje images, or the Trypan landmark with laser precision, gives you a centered IOL coverage with the capsulotomy for long-term visual acuities. Thank you for your attention.